Welcome back, guys. Today we are going to have just an amazing conversation with Dr. Somi Javaid. And Dr. Javaid is a board certified gynecologist, and she is also the founder of HerMD. Welcome to the show, Somi.
Thank you so much for having me. I'm so excited.
Well, we are thrilled because, one of the things Bridget and I have brought up so many times is that we wish there was a place where women in midlife could go to get more than 15 minutes for an annual checkup. No, we're not pregnant. No, we don't want to talk. We want our questions answered, but sometimes we don't even know what those questions are. And when we heard about her MD, and luckily you've opened one in Tennessee. So we are thrilled to be going over there for our annuals coming up this year. But it's giving women a voice in their health. Can you talk to us a little bit about what her MD is and why you started it?
Absolutely. So as you mentioned, I am the founder and a board certified OBGYN, and the founding story always gets me teary-eyed because it's a deeply, deeply personal story. I was pre-med at Northwestern at the time when I got a dreaded phone call from my father telling me I needed to come home. And it was because my mother, who was only 45 years old at the time, was emergently being taken in for quadruple bypass surgery. This is after weeks of pleading with her physicians, saying she was having chest pain, left arm pain, shortness of breath. If any non-doctor in this day and age Googles this, we'll be like, it's this woman's heart. But science and data at the time could not explain why a thin, non-smoking, very active woman would ever present with four vessel disease. Luckily for my family and for my mother, she did survive and is alive to this day and got the intervention that she needed. But, the dismissals and the current healthcare system, it nearly cost her life. So that's the cost of ignoring women and dismissing them is grave. I was pre-med at Northwestern at the time. It was my aha moment that I was going to go into women's healthcare, that we needed an advocate. Fast forward, I'm in my first job and I'm listening to patients and I'm trying to be that advocate I promised both myself and my mother. And the realities of our very, very broken healthcare system kind of smacked me in my idealistic face. And so when the timing was right, both professionally and personally, when I could not find job satisfaction, despite being a physician, right? This was my calling. This was not just a job for me. I decided to open my own doors where women would be heard. They would be partners in their care. They would not be dismissed, that their treatments would be evidence-based and not gimmick or opportunistic like I see popping up in the medscape right now. And the other biggest thing for me was I knew how broken healthcare was for the providers. And if we didn't fill the buckets of our providers and help them feel empowered and allow them to practice medicine that we spend all those years studying to do, that we were never going to succeed. And so really gave the providers work-life balance, mission-driven work. And we have almost zero turnover at HerMD in the provider space because of that very reason.
Do you mind sharing what some of those challenges for providers are when you're not with HerMD?
So we also hate the 15-minute appointment. To me, it felt like drive-through, like pap smears, right? and practicing doorknob medicine. So here you are trying to establish rapport, listen to a patient, do an examination, educate her on her diagnosis and her body, because most women don't know, right, about disease states, their bodies, because we haven't taught them. And then you're trying to give them all of their options. Like, do you want to go with an over-the-counter? Do you want a hormone? Do you want a prescription? Risk-benefit analysis. Don't forget to type it all up, which most doctors, I took one keyboarding class. Like, you have to type it all up, put the orders in, put the prescriptions in, make sure you send it off, and do this all in 15 minutes. There was a study recently published that said an 8-hour workday for a provider in this country is equivalent to just under 28 hours of work. What have we done? What have we done and why? And so that is what is facing our providers. And so we just did a launch event in Indiana, and the physician who is going to be leading there became overwhelmed with emotion when she took the microphone and just said, I feel like I'm finally home. and I get to practice medicine the way it was intended. And so those are the challenges. And so HerMD is a national brand of centers that offers an array of women's healthcare services, but really we are a gynecologic brand that specializes in menopause and sexual healthcare, because nationally less than 20% of OBGYNs are trained, 100% of our providers are trained. And then we offer a full array of services, whether it's hormones, whether it's your annual, and we also do a lot of complex gynecology. So we take care of cervical dysplasia, or what people call precancer. We take care of fibroids, polycystic ovary syndrome. We work up basic infertility. We talk about hormones. We have imaging and surgery in the offices. And then obviously we have a full-blown medical spa, which was very interesting when I launched 8 years ago, because it wasn't really commonplace to offer aesthetic or cash-based services within a very traditional model of healthcare, because HerMD gynecologic services are offered within most major insurance plans. And I say most, but most major insurance plans. So if you think about the Blues and Cigna and Anthem, we take all of those. We take Medicare, we take military insurance. So we're really accessible to a lot of women, which was also a very key component of the business for me.
So if a woman is in midlife and they want to schedule an appointment, what can they look forward to? Because women, we're always saying to our listeners, be prepared, know the questions you want to ask, know the red flags. This is a long, you get full, complete, comprehensive care here. Can you just explain to us an example of what an appointment would look like?
Yeah. So depending on what you're coming in for, our appointment times are 20 minutes minimum, but a lot of new patients will get 60 minutes depending on what they are seeking out. I definitely tell patients to expect to either come in for their annual, and then they can start to tell us what else is going on. And then we can start to order labs and work that up. But I really do tell patients, and I encourage them for insurance coverage to maximize their coverage on their visits, to really separate out those visits. So come in for a menopause consult and get the full 40 to 60 minute FaceTime with us. Bring in all of your questions. We'll review all of the data, your options, your medical history. We may or may not do an exam that day, depending. Like if you're having vaginal pain or vaginal dryness or sexual pain, we may do an exam. Oftentimes we don't. We then encourage people to have an annual, which is routinely just breast exam, pap smear if indicated. We talk about bone health, and we talk about, your medical history, your family history. And so that is the number one thing I tell patients to do, because you will get the most out of your visit if you concentrate what you are coming in for.
And you said, I always get confused about this with pap smears in your annual. How often should you get a pap smear?
Yeah. So when I was training, it's hard for us to keep up with the guidelines. So, some patients it's every year, some patients it's 3 years, and some patients it's every 5. It depends on your medical history. It depends on your family history. It depends on HPV status, and whether or not you've had abnormals before, whether or not you've required biopsies. So there is an algorithm of care that most OBGYNs follow that is not an algorithm set by HerMD, but that's set nationally. And that also dictates whether or not your pap smear portion of your visit will be covered, which is not billed by HerMD. That's billed by, the lab that runs the pap smear. And so that's what I tell patients to be cognizant of. And some insurance companies even get nitpicky. Like most will say once a year. Some will even go as far as one every 365 days. So I always tell people the devil is in the details, and make sure they know their plans.
That's true. With women coming in for their sexual health issues, number one, women are afraid to even talk about it.
Mm-hmm.
So how do they get over kind of asking the questions? And two, what kind of options are available for women who maybe have vaginal atrophy or frequent UTIs, things like that?
Yeah, so it's very interesting to me, listening to women for the last 20 years. I call myself an educator, but I'm always a forever student, and listening to women and their perception of sexuality. Most women will even ask me, what does a sexual health doctor do? And then I'll turn the tables on them. And I said, well, what do they do for men? And, they know the anatomy of a penis. They know all of the male sexual health drugs out there. But then when I start naming off female solutions or even disease states in sexuality, they don't know, because traditionally most doctors aren't trained. There's been stigma and taboo and shame, and a lot of people assume that sexual problems are just in the menopausal years, when in fact, 43% of women struggle with some type of sexual dysfunction. Most women don't know there's a standardized tool that we use called the FSFI, Female Sexual Function Index, that objectively measures what we call all the domains of sexuality. So libido, arousal, orgasm, pain. We can measure all this, and then we can give you a data-driven approach. So let's say for libido, for example, the medical terminology for low libido in a woman is hypoactive sexual desire disorder. There have to be specific. So number one, it has to be bothersome to a patient, right? There are going to be patients who say, I'm done with those years, Dr. Javaid. I don't want to have sex anymore. I'm in a great place. We're not chasing those women down with solutions. If they're truly happy and that's where they're at, great. Number two, it cannot be directly attributable to something else in their life. If a mom is coming in and she's got a newborn baby and she's telling me, I don't want to have sex, I'm like, you go, girl, you get your sleep, you take care of your baby, and that is okay. Some women just need that support. And then there are other women who are distressed by the lack of sexuality. They want to get back to where they were. It's not directly attributable maybe to a new medication or a recent surgery or a new baby. And they want to get better. And so there are 2 FDA-approved medications for low libido. The first one is called Addyi. It stands for Add Your Interest. It is non-hormonal. It works on neurotransmitters in the brain. It increases excitation and decreases inhibition. And that's the state that we need to be in for sexuality. And they know this because they did a study on women. And they showed the women who were struggling with their libido and women who weren't. I hate normal and abnormal. We don't use those terms at HerMD. They showed everyone visual erotica, i.e. porn, and then put women in scanners to look at the brain activity. And in that state, we should be super excited and not inhibited. And that's what was happening in the women who reported that they were having a typical sexual experience. The women who were struggling had the exact opposite pattern. And so Addyi is a nightly pill, non-hormonal, works on neurotransmitters in the brain, and increases desire, and increased a lot of those parameters across that FSFI that I talked about. That was the first one. 2015, it was approved. The second one is called Vyleesi, and that's an injectable. That's actually more like Viagra. It's funny to me that the pink pill Addyi was compared to Viagra, but Vyleesi is on demand. So Addyi takes a while to build up into your system and takes up to 8 weeks to work. And in some patients, we've discovered longer. Vyleesi is an on-demand, and you inject yourself 45 minutes before you want to have sex or you want to have that desire. And so it's a great fix for my patients who come into HerMD and they're like, Dr. Javaid, I have my 25th wedding anniversary trip. Like, you have to fix this weekend. But there are side effects to these medications. Vyleesi, for one, can carry a risk of nausea. I have the best story of a patient who actually got very nauseated, and I said, are you going to do it again? And she said, absolutely, because my desire to have sex was greater than my desire to puke. So I'm good with it, Dr. Javaid. And she was just so happy that there was a solution. And then the third option, for desire in this country is testosterone, which I know for a lot of doctors can be a controversial topic. There is currently no FDA-approved testosterone-only option for women, but there was a global consensus statement that was issued a few years ago that talks about testosterone replacement, that it can be safe in women, that it doesn't cause increased risk of breast cancers, that it doesn't increase, cholesterol and their lipids, as long as it's done correctly. And so there are a multitude of options for just that one issue with sexuality, right? We haven't even gone into the question you asked me, which is what we call GSM, genitourinary syndrome of menopause. It's like the honeymoon phase again, what patients describe, they're getting UTIs after sex, or they're having frequent vaginal infections, or they're having dryness, or they're having sexual pain, or what we call dyspareunia. And there are a lot of options for this that are prescription, that are over the counter. So I'll give you one example. So Intrarosa is a vaginal insert. It is hormonal. Very, very little gets into your bloodstream. So most patients who aren't even candidates, let's say for systemic hormones, are still candidates for this. We just ask their oncologists if they have cancer. We ask their hematologists if they've had stroke or they've had heart attack. We'll ask their cardiologist, but most of these doctors are okay with it because those hormones are considered locally acting. And what's happening in the female genital tract or pelvic tract is that our vaginas are designed like an accordion, and they have these thick, beautiful folds called rugae, and they can stretch and accommodate partners. As we age and estrogen and testosterone decrease, the skin gets thinner. And so we can't fight off infection. There's not as much elasticity. So instead of like stretching and feeling very lubricated, the tissue gets very dry, it's thin, and it can tear with pressure, intercourse, or with stresses. And so, we recommend moisturizers, we recommend lubricants, we recommend vaginal hormones, and Intrarosa isn't the only one. I particularly like Intrarosa because it's a unique formulation, and they have, once again, that FSFI data that it helps with orgasm and it helps with arousal. It's not just helping with the dryness and the pain. And then at HerMD, we have unique treatments like radiofrequency and microneedling that are great options for patients who are like, listen, I don't want to put something in my vagina every day, or I've had an adverse response to hormones, or despite the fact that they are local, my doctor is just not okay with it. And so we will treat women instead with this 15-minute procedure in the office that really helps them with incontinence, dryness, pelvic floor health. And so that's a really nice option. The issue with those treatments is they're not yet covered by insurance.
Right. We
That
hear
was
that
going
a
to be my
lot.
question.
Yeah.
I was going to ask that.
Yes.
Yes. Mhm.
But for women with high deductible plans, and particularly women who are facing incontinence, it is still much, much cheaper than going to the hospital and having surgery, let's say with a urologist, right? Like a sling or a bladder procedure. And so a lot of women will choose these options. Some women, their hormones can be upwards of $200 to $300 a month if they're not covered. And so it's more cost effective for them. And women will do this in conjunction with Intrarosa. And there have been some studies showing how effective, like let's say over-the-counter lubricants and vibrators are versus Intrarosa with a energy-based treatment. And obviously those women fare the best because you're stimulating that tissue. And if you look at before and afters of the vagina and the vaginal tissue, it's profound what these treatments can do, because basically you're causing purposeful injury. So you're purposely injuring the tissue with energy. And then the body goes, oh, I have to repair this. And so that's how you then get a thickening of the tissue. And where a lot of people got into trouble, or when these devices ended up in med spas and they were making all these promises and promising 60-year-old women they're going to walk out with 19-year-old vaginas. It's not going to happen, right? But is your sexual pain going to get better? Your dryness, your prolapse? Yes. And you also have to know what you're doing, and you have to prick the appropriate patient, and you have to counsel them. And so we have had tremendous positive impact and results with these energies and these therapies.
So the Intrarosa, is that prescription or is that over the counter? I forgot what you said.
It's prescription.
It's prescription. Yeah. Okay. And the thing is, it's so hard to get the word out. I know about this because of what I'm doing, and I'm researching it. But so many of our listeners have no idea, or people that find our
if they don't listen to us, they have no idea.
They really have no idea. But they might stumble across our Facebook group, and then they will come up with the question, and I really feel for that. Is there, I don't know what to do. I know starting something like HerMD, doing podcast. I would love to see a commercial on, for the pink pill, for all of these things on TV, like I see Cialis and Viagra and everything.
There are commercials for Addie now, but the problem is, and you guys know this, there were a lot of restrictions with female sexual health companies, and it's going to be maddening to you. They were seeing the ads as no different than pornography. I mean, HerMD has had some of our stuff taken down, and we, of course, talk about everything as sexual health, and we're talking about evidence-based medicine, and we're talking about clinical research trials, and we're talking about options, often prescription options that are covered by insurance. And even some of our stuff has been flagged. And it's amazing to me in this country, if 26 FDA approved options for men, and only 2 really, maybe a couple if we consider Intra Rosa, but a handful for women that are FDA approved. And so I did a TEDx talk about the profound gender bias that exists, number one, in healthcare, right? Less of the VC dollars go to us, less research. Women are underrepresented in clinical research trials. There's profound gender bias. Whether it's a male or female physician, we tend to dismiss female pain. I mean, you guys, we were talking about the Below the Belt documentary, and that one woman said, I'm more believed and validated when I have my male partner with me. That's horrific.
Yeah. Mm-hmm.
We wait longer in emergency rooms than our male counterparts for pain medications. We're more likely to die of cardiovascular disease and heart attacks than male counterparts. And even though we outnumber men in the clinical workforce, we are not the decision makers, right? We do not outnumber them in the C-suite, because everyone asks me, how did female healthcare get here? How are we here? And despite the US being very progressive with our musical lyrics, when we talk about sexuality on TV and movies, I still think globally, we are well behind a lot of cultures when it comes to taboo, stigma, and shame around sexuality, particularly female sexuality. I was never taught, I'm an OBGYN. We learn about the vagina and the pelvis, and I was never taught about sexuality for women, talking about pleasure for women, talking about arousal, talking about orgasm. I learned about contraception, obstetrics, pain, surgery. I was never taught how to talk to women about sexuality beyond the reproductive years. That's really sad.
It is. I think one of the things that makes HerMD so revolutionary is that your mission is to kind of close that gender gap in healthcare, which is very slow. A lot, like you were saying, a lot of dollars in research don't go towards women related issues. And the fact that you're saying, I'm going to give you somewhere between 20 and 60 minutes to talk about your gynecological health, it shouldn't be revolutionary. Like that shouldn't, is it because of the insurance companies that it's a challenge? Because it's not easy to do what you're doing. You have to really marry it with other things in order to make it available to women.
Well, and that's the challenge I faced as a founder. Like, this is a great idea, having all this time and not going concierge, because that's so limiting as a provider. A concierge physician, they do great work. They obviously get to spend a lot of time with their patients, but most of my patients can't afford it. It's thousands of dollars a year to belong. And oftentimes you still have to pay for your visits, or they're still billed to insurance, depending on how they're designed. And so at HerMD, most of our providers can see 1,500 to 2,000 patients each. So think about the access. So I was like, I'm not going to charge membership. I'm not going to go concierge, but how am I going to do this? Because insurance companies, I would love to tell you they're giving me outstanding contracts. They're not. They're still considering HerMD a new company. They're much kinder to hospital systems. And so it was like, how do I bring in additional revenue to make this work? And so it was putting the surgical center in, it was, putting imaging in, putting all of these other services, and then it was adding a medical spa. And at first people did not lock on. They're like, what is she doing? But I knew aesthetics was a very rapidly growing industry. I knew that you didn't have to go to residency, right? We're not doing facelifts or anything like that. And so I was like, we have providers on site all the time. So you want to talk about safety versus a traditional Medi Spa, unbelievable. They have trust and rapport with us, and they're telling us about all of these issues. When they come in talking about, for example, PCOS, polycystic ovary syndrome, we take care of their fertility issues, we take care of their abnormal bleeding, we take care of their cysts, and we do their imaging. But a lot of patients with PCOS will have weight gain, and they want to talk about body shaping, they want to talk about nutrition, they want to talk about, I hate the word diets, let's say food plan.
I was just say lifestyle changes.
Yes, lifestyle changes. But then they also have hirsutism, which is abnormal hair growth, and male growth patterns because of hormonal issues. They have higher testosterone levels, which causes hair to grow, upper lip, chin, and they'll have darker, thicker hair. And so they want to talk about laser hair removal. Well, guess what? We can offer that. And we can offer stronger lasers because we have doctors on site. Our menopausal patients, they want to have their annuals. They want to talk about their breast health and their bone health, and they want to talk about hormones, but then they want to talk about aging and what's happening to their skin and their sleep. And they want to look and feel better. And so they want to talk to us about Botox and filler. And so it's just a very natural progression in HerMD centers. I purposefully made sure that the providers, your surgeons, your researchers, your doctors, the ones who are writing your prescriptions, are not the same people that are taking care of you on the spa, because I want you to feel no pressure to go to the spa. And I want you to have that independent experience in the spa if you so choose to go there. And I think that is the other beautiful thing about the HerMD spa and the HerMD experience. And so that was the revenue stream that supports the really long appointments. And so it's a win-win. The other thing is they said, you'll never get your aesthetic staff and the med staff to ever understand each other or respect each other. I was worried because I've been a professor, I've been in academic institutions, and it could not have gone any better. There's a lot of cross training, and it's amazing. Our aesthetic staff will catch things. Like if they see the hair growth, they'll say, hey, have you been worked up for PCOS? Like, has anyone ever talked to you about this? And same with the medical side. They will, say, has anyone ever talked to you about laser hair removal? Has anyone ever talked to you about acne treatments? So it's a match made in heaven, really. And the staff love learning from each other, and they love the cross training. So it's a really empowering environment.
And can you share how many HerMDs are open right now?
So we have 4 open right now: Ohio, Kentucky, just north of Indianapolis and Carmel. And then we have one in Franklin, Tennessee, outside of Nashville. Woo, woo!
We're very excited about that you chose that one.
Yes.
New Jersey is under construction and slated to open in early May. And then Atlanta, Georgia will round out our last location this year, with many, many more to come, because that is one of our goals, is increasing access to care.
Which is such a gift to women, especially in our demographic. And I also want to make women aware that the states you do have a brick and mortar location, you can also do telehealth by that state.
That is correct. So they, and we do take insurance for our telehealth visits. So yes, where we have brick and mortar locations, we also offer virtual care, because some of our patients are driving hours and hours away to access this type of healthcare. And they said they've seen 8 or 9 gynecologists and they haven't gotten a diagnosis. And they're just so excited to be, seen and heard. I was at the new locations and I was doing some training, and I was listening to the providers, and I said, how is it going? And they said, we didn't expect so many tears. And it's not tears, I'm sad. It's just tears of gratitude. Like, thank you for being here. Thank you for listening. And so it's a lot to unpack. It really is, but our providers are so fulfilled, and we're just so excited to be in these new locations.
It's so great to be a woman of my age, 55, and other menopausal women, to have someone that is really, available, and that will spend that time with you, because typically we're going to OB-GYNs, and most of the women, like Colleen always says, are pregnant in the room.
I don't want to be around pregnant women. It could be contagious. I don't want to be around. I mean, I just don't, I understand when I was younger and they would say, oh, the doctor's running late. There was an emergency delivery. I get that, but I don't want to hear it anymore. Like, you know,
Yeah.
And I get it. When you're not in the thick of that anymore. And I think that's where we also have really failed women. And we were trying to understand. And I read a fascinating article the other day about, we're going to spend 40% of our lives in menopause because of increased life expectancy. So just think about that. 1.1 billion individuals will be menopausal by 2025. And yet, if you think about it, historically, we have concentrated on women as vessels for pregnancy, which is amazing. Like, I'm a mom, I have 3 kids. Like, I love that. Or objects of male pleasure. Think about that. And why? They were like, why? Aside from all the other barriers I told you. And they think it's because traditionally, historically, gynecology has been a very male-dominated field. And it is from the objective of the male perspective that women were looked upon in science, in gynecology, in data. And so that is why there's an extraordinary focus on the reproductive years, which are such a small, if you think about our lifespan, such a small amount of time. Now, I'm not saying that those women don't deserve the data, the research, the funding, everything that's going on and the attention, but we have really forgotten about women after they're done having babies. And they want to come in and they want to talk to you about their sleep, their anxiety, their depression, their mild cognitive decline, what's happening in their relationships and their sexual health. And they want ownership of that. And they want to understand what's going on, and they deserve to be visible and to be heard. I think you guys were there when I talked about one of the saddest stories I've ever heard in gynecology. And it was a woman who was struggling with GSM, and she was never told it was GSM. And so then it led to low libido because, who wants to do anything when it hurts? So sex was extraordinarily painful. She wasn't driven to do it, but adored her husband, and he left her. And she was at a lecture of mine, and she was, listening to me, and she was like, oh my God, that's all it was. Like, I needed a suppository or potentially, this treatment that you're talking about, or a lubricant or a moisturizer. She lost her relationship because of menopause. Just think about that for a second. So for all the people who don't want to invest in women's healthcare or say they're not going to die from it, how many conditions do we treat for people that don't lead to death, right? But lead to quality of life. So why are we always putting that parameter or that limitation when we're specifically talking about women's healthcare, conditions? And so it was so sad to me, and she was crying because it was, when she saw me in the office then, because it was our aha moment that it was preventable, right?
Yes. Yeah.
It was preventable. Yeah.
There's so much emotional attachment to that too, with anxiety and depression. And it really is a 360 look at a female, which has really never been done before. They piecemeal us and they give us medication for certain things, but to look at the whole picture of a woman's experience is unusual.
Well, and that's the way women need to be treated. It's called the biopsychosocial approach. You take her medical history, you take hormones into effect, but you also take into account what's going on in her life. And so, we showed in studies that we presented recently that, for example, with Addie, we have almost an 80% success rate at HerMD because we address the pain, we address the relationship issue, we get them into pelvic floor, physical therapy, we get them into counseling. Right. And so if you don't address the shame, the isolation, the guilt that women experience when their sexual being is not who they used to be, they'll describe themselves as broken, undeserving, and they're losing relationships, their self-confidence, they're going into depression. And so people and individuals who are sexually active are much more confident and they're healthier. And so if you are able to repair that and fix that for an individual, you are fixing so many other aspects of their healthcare. And so at HerMD, sexual healthcare is healthcare. Menopausal healthcare is healthcare, like period. And there is no difference in talking to your doctor about your vagina or your vaginal health than there is about talking about an earache or a headache. And, that's the first thing I tell my patients, like, let's get rid of any shame or stigma that you have or fear about talking about your own body to us. We're here to help you. It also helps that HerMD centers are gorgeous. Like, they're a dream come
Oh,
true.
yes. Yes.
For me, because think about that too, like what we have accepted as the status quo, like horrible lighting, cold offices, and please get naked and wait here 2 hours for your provider who's delivering babies. Like, why have we put up with this for so long as women? We would never accept it for those we love, but yet we've accepted it for ourselves. Yeah.
And I can say from going to your opening for the one in Franklin that it is a beautiful facility, and it's light and bright, and there's windows, and everyone was just so excited that was there. You had to have over 100 people at the opening, and everyone was just so excited to learn, and the providers that were there were excited to share the information, that it was contagious. Like, you just wanted to be there. It was really a great event.
We opened Nashville with over 500 women on the wait list. And this is being duplicated in cities across the country. So it just tells you the enormous gap that we have in healthcare for patients who have menopause, who are struggling with their sexuality, and even for these advanced gynecologic, conditions like fibroids and PCOS and endometriosis. It just, it's astounding to me. And Nashville, there's great healthcare. There are great academic centers. But yet women are not getting the care that they deserve. And I think the other problem is, the time sink, like we talked about. And then we've become so super specialized in this country that women get bounced around from provider to provider, from place to place. I heard a story when we were presenting at Columbia University about a woman who had fibroids, which led to profound anemia. So she was sent from her internist to a hematologist, who then was giving her iron transfusions and blood transfusions, and she wasn't getting better. And finally, she took it upon herself and said, hey, guys, maybe I'm not getting better because I'm bleeding quarts a month. But no one asked her about her menstruation. And she said the doctor she actually brought it up to started blushing. And so she said, how long would that take at HerMD? I said, one visit, because your menstrual history is part of your history, whether you're still menstruating or not. And then we ask you about your bleeding. That's like one of the things we get into. We would have drawn your blood, obviously confirmed the anemia. And then we would have, if available that day, the ultrasound tech, we would have taken you into the room, or we would have scheduled you ASAP. And so I said 1 to 2 visits tops. And she said it took, I want to say, over a year. I mean, that at an unbelievable institution in this country. And we are seeing women who have gone to these amazing centers that are meccas of research and experts. But once again, this pinballing of women from expert to expert, and no one looking at, like you said, the whole clinical picture. Well, you have depression, your primary care might put you on antidepressants. Well, is the depression for menopause? Because we definitely see that increase. You're having, mild cognitive decline. You're being sent to the neurologist, but wait, we know this happens in menopause. So, you're having joint aches, you're being sent to the rheumatologist, but wait, estrogen is hydrophilic. It pulls water with it. Dry skin and dry joints, that can happen in menopause. Going to a weight loss specialist, they're sending you to a sleep doctor for insomnia. It's like, what are we doing? There's no like holistic approach to say, hey, maybe all of these symptoms over 30 are attributable to your menopause or even perimenopause. And I think that's the other issue in this country, is that sometimes we have very narrowed tunnel vision when we're looking at patients.
Mm-hmm. Yeah. We're wearing blinders to that. Yeah.
Right. And I think most women and men can relate to that you go in for one thing, but they don't bother to ask you, well, it could be related to X, Y, and Z. Mm-hmm. So the more that information you can give them, the better, honestly. And that's why we're so excited that HerMD, I mean, selfishly, we're excited that
yes,
you're local.
We are yes. I think we first heard you speak at Womaness, a Womaness event almost a year ago. Right. And you were talking about opening the office, and Colleen and I were, We were about to, like,
get
on the
on the
way
wait
home, so
list.
excited, driving about it, talking about it. Then you also invited us to, well, Colleen went to your great open house. That was my
It happened to be our
birthday.
birthday.
I was on
so-
my birthday. And so, well, we have the same birthday. Franklin, HerMD, and I have the same birthday.
I love that.
And, I'm just 55 years older. And then you also invited us to Below the Belt, the premiere that you hosted.
The event.
The event that you hosted for the premiere of that documentary, which was amazing, fascinating, heartbreaking, about endometriosis and what women in this country are facing when they have this. So just getting this word out like this is so important. And just the people who made the documentary, the people hosting the documentary in the various cities, that's just amazing. So thank you so much for all of that.
I think the night was very powerful because it brought storytelling back to the forefront in medicine, and it humanized that condition. And I think it made us all more empathetic. When we walked out of the theater that night, we may have been sadder, we may have been depressed, but I think we all were extraordinarily moved. And even myself, I fought with the insurance companies. I've done endometriosis surgery, I've diagnosed a lot of women, and I was sitting in the audience and I was crying because it was my first time getting to see it as well. And I've been in those rooms with those patients, through their fertility struggles. The amazing thing that came out of that, for me personally, was all the social media outreach, like, Dr. Javaid, you did my endometriosis surgery. I finally had a baby at 43. And I was like, oh my God, and I think for me, are we an endometriosis center like Vanderbilt with dedicated research to endometriosis? No, but what we are is a place where we will partner with you. We will get you the medications. We will fight with your insurance company, and you will not face a delay of 10 years at HerMD. Like, you guys heard the statistic that night,
Right.
up to
10
a
years.
10. Oh my God.
Yes.
It's just
Why?
unacceptable.
And just the payment, the father or the mortgaging their second mortgage on their home to pay for his daughter's surgery. The one lady that took out a credit card debt to pay for this surgery. And there's
Because
only,
it's not covered by insurance.
Well, and and then you heard the peer-to-peer, you heard the doctor from Vanderbilt. Oftentimes you will get on the phone with a peer and you're talking to them about a gynecologic issue and basically begging for them to cover this procedure, medication, intervention. And they are not even in the same field. It may be a cardiologist, a pulmonologist. You guys, I am really smart, okay? I consider myself an expert when it comes to gynecology, but what did I say to you guys? I'm a student. I'm still learning every day. I always say that I'm a 47-year-old work in progress, and I learn from patients. I learn from my peers, but I would never get on the phone with a cardiologist and start talking to them about standards of care and what should be covered and not covered. Like, why is that acceptable? And they are the ones declining oftentimes the care. Like, yes, a lot of times they will say yes, but a lot of times, oftentimes the answer is no. And it's maddening to me, and that the burden is put on the patient and the provider. So remember, we talked about those 15-minute appointments, right? Imagine then that you're also trying to do these prior auth phone calls in between patients. I mean, that's the way the system is set up right now.
So that you can't get it done, and it's not covered, and these people are forced to take credit card debt and anything else to get
second mortgages on homes.
It's so unacceptable. But
it's unacceptable. It's sad. But I did find hope with the one woman who was speaking, that they have really partnered with the insurance companies, and they have figured out a way. And didn't she allude to the fact that they have almost 100% success rate in getting a yes, but they just had to figure out how to document, what to say, what to do. But that was a huge, time sink and ownership that they had to take, and learnings that they had to do. And I'm telling you that offices around the country do not have those resources. Like, you would have to have a person on the phone dedicated to getting that done for you all the time. We do at HerMD have someone at each office who's in charge of all the prior authorizations. We take care of that for all of our patients, but I'm not going to say that we have 100% success rate. We definitely hear no. We fight. And we'll
Right.
go back and we'll fight for appeals and we'll keep doing it. But we still unfortunately hear no.
Thank you so much for coming on the show. We appreciate, I just don't think you can even understand how much we appreciate the fact that there is a facility out there, and now several of them, where you are addressing the concerns of women and making them feel seen and heard and a partner in their medical care, which to date we really have not felt that. So thank you for coming on this show. We appreciate it.
Thank you both for being HerMD fans and for inviting me today. This was the highlight of my day. I had so much fun talking with you both.
Aw,
Thank
thank
you.
you.